So, first of all, and just like every other speaker that showed up tonight, I'd like to thank all of you for coming out to hear us tonight. I think everybody had a pretty important message to share, and hopefully you're getting something out of this. As my introduction started off, is yes, I'm an assistant professor of surgery at Hermann Memorial in the Medical Center. And what that means is that I spend a bulk of my time teaching medical students, residents, and fellows who rotate on our service surgical techniques and skills. But what I also am is I'm a major in the United States Air Force in an active duty role. And so if you happen to know my commander, you might want to tell her that I will have my hair cut before the next time we see each other. My military experience has given me a broad way of seeing the world. I've been to a lot of different places. Most of you would never probably pick up in a travel brochure, for good and bad. But it has given me a different strength and given me better insight of myself as a surgeon and as a human being, frankly. And so when I was given the opportunity to come and talk to you all at the Sugarland TEDx event, I jumped right in like I always do with both feet. When I was told of the theme of the event, I'll be honest, I was a little taken back. I wasn't quite sure how I was going to address the group. You see, I grew up in a family of 4 boys, and there was a lot of machismo and testosterone going around. I spent a good portion of my early years trying to fight for a position in the family, literally. And so I went back and I started thinking about all of my experiences and who had had a huge impact on my life, and immediately came to my mom. And if she saw this picture that I'm showing all of you, she'd probably kill me. At a very early age, my father left home for work reasons. And as my older brothers decided to go off to college and work and whatnot, I was left at home with my mom, and her singular focus was raising me. One of my earliest memories that I have with my mom happens to be a tape recording I have. She used to communicate with my grandparents by tape before cell phones and all the other things we take for granted. She would record our voices and send them to Grandma. The memory I have is telling Mom how I, in great detail as a 3-year-old, I have to say, how I wanted to be a doctor when I grow up. I don't know how that all played out, but as I look on my medical career now, I remember one thing that my mom told me. You can do whatever you put your mind to, and you have to stay focused. Another important person, and I can't underemphasize what it's like to have a strong partner in life. This is my wife, picture not taken that long ago. Wonderful lady. I don't know what people mean when they talk about soulmates and all the other stuff, but I'm pretty sure God had us in mind. I can't imagine another woman who would put up with my opinions, my absolutely horrible, horrible work schedule, and my inability to say no, I'm here right now, to anybody who asks for help. I joke with my friends all the time, and I say, she's a single mom raising 6 children, 5 under the age of 10 and a 40-year-old, case in point. What was her advice when I talked to her about tonight's event? Share, be yourself, share your story. Just be honest. I came home from Afghanistan in 2011 with a newfound interest in veterans issues. And we've already talked about some of those tonight, but did the audience know that we have 22 million veterans alive in the United States right now? Of those 22 million, 8% are women. 15% of the active duty force right now is female, and 11% make up the group that has deployed to Iraq and Afghanistan. Women are starting to fill roles in a combat situation and doing an admirable job with it. One of the women that's doing that is a good friend of mine, Dr. Dolly Skeet. She's an orthopedist and works in Nevada. This is a picture of her taken from People magazine. They did a great write-up on her when we came home from the war. She's holding her little son there. She's a graduate of the United States Air Force Academy, and one of the things that we would talk about endlessly into the end of the night was her concern that she had seen so many of her friends and classmates from the academy coming home with so many issues, and that we weren't addressing them appropriately. We weren't paying attention to it. And from her mentorship and insight, I have gotten my place in life. This is a picture of me on the left of your screen, or right of your screen, left of my screen. That's me in Bagram Air Base, Afghanistan, last summer. We were in place, this surgical team and I, during the busiest summer of the entire conflict. Taking into consideration we've been there now for 12 years. The injuries, I don't even have time to describe to you, they were horrific. We described one of them as the Bastion Special, which was triple amputation and a blown-off groin. These young men and women were coming in with horrible, horrible injuries. It was so bad that you had to really isolate yourself emotionally from these patients in order to make things make sense. And speaking as a veteran, we do go through a lot of different, have a lot of pride and emotions, and we have to justify things in our own minds a lot of times to make sense of the conflict in order to feel that we're doing an adequate job and we're there on a just cause. And when you see things like this that popped up, this just popped up three weeks ago on CNN. If you look, it's absolutely a disgrace in my opinion. We have 1 million people who are going to apply for veterans benefits this year. The number that really shocks me and stands out is the fact that over a quarter of those people are going to wait for over a year to get those benefits. It seems like we could do better than that, in my opinion. These kids are coming home with PTSD, post-traumatic stress disorder. In the reserve groups, it's greater than 35% of those coming home. Active duty is a little bit less, 15%, but I'll bet if you had an honest cohort of those patients and you asked them truly if they were suffering from PTSD, that rate would be much higher. They're afraid of what that diagnosis will mean for their career, so they're saying no. What does PTSD do? It increases addiction rates, increased domestic violence, increased divorce. Since 2003, the armed forces has seen an increase of 73% of divorce, increased unemployment, increased homelessness and suicide. As a matter of fact, for every 5 successful attempts at suicide in the United States, one of those is a veteran. There are a lot of different issues that we're facing as a society right now when we talk about healthcare. And I don't have enough time to really delve into it all, but I can speak as an expert of what's happening in the military medical field. We're seeing a budget crisis and a crunch. We're seeing decreased military funding, and it's especially hitting our medical corps. That's an easy topic to pick up on, but one of the unseen things that's happening is we're seeing decreased access for our veterans and our military personnel. No access. It's very difficult. And what does that mean? It means that the doctors that are there are no longer keeping up with the skills that they need. Patience is practice, is skills. Those all go hand in hand. We're seeing fewer deployable physicians now in the military for a number of reasons. We're seeing closure of medical treatment facilities. The medical treatment facility that I was at prior to coming here was Wolford Hall. Closed its doors in 2009, is no longer a trauma center. One of 2 in the United States, we're now down to 1, Brooke Army in San Antonio. Less and less military trauma and deployment experience is a huge problem. So where do we go from here? Well, the future of medicine, especially in the military, is in flux. There's ideas that are out there. Some of the ideas include, well, why don't we take all the branches of the services and combine them into one military medical corps that then treats everybody? Air Force, Marines, the Navy, one service. But that doesn't get to the root of the problem I just said to you guys, right? Decreased access, decreased numbers of patients, decreased competency for the doctors, nurses, and staff. It's a big problem. What about the reservists? Maybe we could turn to them. After all, we are a volunteer military service, is that correct? It's true. How about that private doctor who will be deployed for more than a year? How are they going to come back to a practice that's no longer existent? If they get deployed for greater than a year, they're probably going to have to lay off their nurses and their staff, not to mention the referral pattern, completely gone. So they'll have to come over and restart all over again. Big problem. So not very many of those people are going to say, yeah, I'll sign up, even though if they feel in their heart it's their civic duty. Another option, which is the option that I fulfill right now at the University of Texas Health Science Centers at Houston, is taking active doctors and putting them into a big facility like UT Houston, where the patient volume is large enough, and that if I leave unexpected for a deployment, my partners can pick up the slack. And when I come home, I just step right back into a busy practice. These are all options on a global scale of how to take care of it from the military perspective. I see a problem, Dr. Skeet saw a problem, and I have another solution. What if we took, rather than bringing doctors into the military, as we've done for years and years with the Health Professions Scholarship and the Military Medical School in Bethesda, what if we changed the paradigm and brought the military to the doctors? Well, I'm proud to announce that we're doing just that right here at the University of Texas in Houston. I've written a curriculum that discusses patients and how military issues affect each one of us, veterans issues affects each one of us. Case scenario and a veterans issue workshop. For those of you who don't understand what I'm saying as far as a case scenario, what it is presenting a case, a patient, as they would present to your emergency department, your hospital, or your clinic, with all the medical issues on the table. Traditional medical education has been siloed much the same way as our educational system across the country into specific subjects. So medical school would cover things like histology and anatomy and biochemistry. Taking a case scenario melds them all together so that you see a holistic approach to medicine, the patient, which is important. In this particular curriculum, we talk from the very top to the bottom. We talk about the idea of pre-deployment medicine, immunizations. We talk about the environment these young men and women will be sent to. High altitude, for example, in Afghanistan, and how that affects your physiology. Always coming back and talking about the pathophysiology. This particular case, it's a young Marine who gets injured by an improvised explosive device or a roadside bomb and loses both of his legs. We talk about the anatomy. We talk about the pathophysiology of the coagulation problems. We talk about the point of care and how those medics on the ground take care of the patient. We then continue on the continuum with this patient. We bring him home. We talk about how it affects his wife and his kids. We talk about the societal problems and how we're going to integrate these patients back into our society. It's a top to bottom educational change. The most important thing that I've done, and we've done at the Texas, at the medical school, is bring in experts from the fields. Now, I'm a trauma surgeon, and I deal with a lot of these issues every day, but I'm by no means an immunologist or deal with infectious diseases. So what I've done is ask the medical school to write parts of the curriculum. So each one of the areas is taught and integrated by experts in the field. The other nice thing about a problem-based scenario is that the students run the curriculum in a sense. As new subjects pop up, they can go and research them, come back into small group and discuss them. We supply them with a facilitator, then make sure all the core ideas are taken care of. It truly is a change in thought process of how you educate future doctors. This is done in the second year of medical school. We're not done yet. What we'll do is we will come back in their fourth year and run a veterans issue workshop. What does that mean? Well, we'll cover a lot of the same issues again. We'll talk about the pre-deployment medicine and hit all the high points. These gals will be very close to graduation at this point. And I think it's extremely important to start talking about access for them. We'll cover things like the VA and the USO. We'll talk about things like the Wounded Warriors Project and how that integrates into the patient's overall beneficial in their outcomes. So you're sitting in the audience right now and you're starting to think, well, how would I integrate this into my practice? Or how would I integrate this into the teaching of the people that work with me? I would say there's 4 things you got to keep in mind. Whatever you are doing, it's got to be focused on the end product. For me, it's patients. This education has to be focused on patients, not silos of different subjects, but the patient, him or herself. It's got to be multidisciplinary. I just took a little bit of time explaining to you what I meant by multidiscipline, right? Different experts from different fields all contributing. Multidiscipline. It's got to be timely. Probably more than anything, it needs to be timely. So when the medical advances or advances in whatever field you're in come out, they're taught to your students. It makes no sense to teach people 30-year-old knowledge. What's the point? What are the benefits of the things that I'm talking about here tonight? One of them is I talked about access. Access for our veterans. Completely lacking in some instances. What I've talked about is increasing access for those patients. How? There's more people dealing with the issue. More people understand the issue. Again, a big chunk of our population are reservists who have deployed, and they'll be seen in the primary care clinics of your local civilian doctor. They're not coming to the medical treatment facilities, and probably a good chunk of them not coming to the VA. We're increasing access with people that understand the problems and can deliver care. The other big thing is translational medicine. And what do I mean by translational medicine? Unfortunately, one of the fortunate things that happens with military conflicts is that medical technology advances rapidly. With every conflict, new things come out of it. I'll give you a couple of examples of what's happened in the recent conflict. One of them makes complete sense. When you bleed whole blood, right? The blood that comes out of your body is the way God created it. What do we do when we decide we're going to transfuse a patient in the hospital? We split the blood into separate, disparate products: plasma, platelets, and red blood cells. Patients don't bleed that way. They bleed all of that together. And so with the data driven, we have started to transfuse patients whole blood, or at least in ratios that make sense compared to whole blood, and started to save lives. We're using technology that's looking at the coagulation, the way blood clots, and we're using different medications to help stem the tide of bleeding. We're looking at different ways of treating the patient, point of care contact in field, in theater, transfusing the patient on the ground when the helicopter lands. Chest tubes, intubations, all of those things done by paramedics trained to do it. One of the biggest advances that's happened is the way that we transport patients intra-theater. And let me give you an example of that real fast. Young man or woman gets injured in Afghanistan or Iraq. A medic on the ground renders first aid buddy care to that patient, first aid. Within minutes, a helicopter lands and flies that patient to a forward operating base where doctors meet the patient and stabilize them. That day, probably within hours, the patient is flown off to a combat support hospital like I was at in Afghanistan, where we do life-saving interventions to save that patient's life. That night, the patient is boarded on a C-130, C-17, and flown halfway across the world, either to Germany or all the way into San Antonio, where definitive care takes place. All of this I have just described to you happens within 48 to 72 hours. Flying halfway across the world, what does it take you to get LaGuardia to Honolulu? We flew a critical care patient with all of those issues that far in that period of time. What does that do for the healthcare community here in Texas? If you could figure out a way to transport patients quickly from Harlingen to Houston and do it successfully. One of the most amazing statistics I ever saw, and I am very proud to be a part of it. If you arrived at the Combat Support Hospital in Afghanistan, we had a 99% survival. All you had to do was show up through the door and you were going home. What if we could do that here? I'm asking you to think about that for a second. So when I start talking about a new curriculum, a new paradigm, a new way to teach doctors, translational medicine, what we are doing to save heroes could save you and me. I know it's a lot to swallow for a lot of you. I talked a little bit about medical jargon. I hope I didn't bore you to death. I see some eyes wide awake, and I'm happy to see that. I would like to thank the women in my life because they have given me so much encouragement and support. My mom, my wife, people like Dr. Skeet. Thank you for everybody for your attention tonight.